Hello, everyone, and welcome to today's industry webinar, Telehealth, Past, Present, and Future. My name is Alex Taylor. I'm the Marketing Manager here at Azalea Health and will serve as your moderator for today's presentation. Before we get started, I'd like to go over a few items so you know how to participate in today's event. Everyone on this call is listening in using their computer audio system by default. If you'd prefer to join over the phone, just select telephone in the audio pane on the right-hand side of your screen, and the dial-in information will be displayed. You'll have the opportunity to submit questions during today's presentation by typing your questions into the question pane of the control panel. You may send in your questions at any time during the presentation. We will collect these and, time permitting, address them during the Q&A session at the end of today's slides. Also, please note that today's slides will be shared in a follow-up email after this presentation in case you want to review again or share with any of your peers. I would now like to introduce today's speaker, Reeya Patel. As the Associate Director of Health Insights at Azalea Health, Reeya consults with health systems and physician practices to offer professional services and solutions targeted at navigating the regulatory environment of healthcare, streamlining operations, improving workflow, and maximizing revenue of ambulatory practices and hospital outpatient clinics. She offers keen insight to the organization on topics that range from rural health, technology-enabled solutions, regulatory updates, and quality reporting programs under MACRA. Reeya received a Master of Public Health degree in the Health Policy and Management from Emory University and is a graduate of the University of Georgia College of Public Health. She continues her academic pursuits by currently obtaining a doctorate in health administration at the Medical University of South Carolina, specializing in information systems and leadership. Throughout her academic experience, she's engaged in research and coursework, specializing in public policy, operations, financial management, strategic planning, physician performance, quality improvement, and analytics. Prior to joining Azalea Health, Reeya worked in nonprofit and charity care, community outreach, and nonprofit grant writing with strong focus on rural health and increasing access to care. With that, let me turn today's presentation over to you, Reeya.
Thank you so much for the introduction, Alex. Hi, everyone. Like Alex mentioned, today we're going to be talking about telehealth. We're going to spend a little bit of the beginning talking about, what is telehealth, some definitions for the different forms of telehealth that are out there. But really, I want to spend a bulk of this webinar talking about some of the legal and regulatory limitations to telehealth and talking more about how to actually get reimbursed for providing telehealth services. So let's jump right into what is telehealth. So there's three common forms that have been accepted as different forms of telehealth. The most common one that you probably hear of the most often is live video. Now, this form of telehealth is using an audio and a visual connection so the provider and patient can be connected into a visit. Now, this is the form of telehealth that is reimbursed in most cases. Another form of telehealth is called store and forward. Now, this typically applies to specialties that use a lot of medical images. So you could think of radiology, dermatology, specialties like that. It's using images that are taken and then sent to a provider when needed. So because this isn't happening in real time, the reimbursement is a little bit more limited than it is with live video. And the third type of telehealth is called remote patient monitoring, or RPM. Now, this uses a range of different devices that actually monitor clinical signs for a patient from a remote location. So you could think of blood pressure, vitals, things of that nature. And really similar to store and forward, this isn't happening in real time, or there's a lack of a face-to-face visit. So reimbursement is a little bit more limited when we think about RPM when we're comparing it to live video. Now, I just wanted to touch really briefly on some of the adoption statistics. You guys have probably seen numbers really similar to this across the board. So just kind of showing that telehealth now has gained a lot of popularity, and we're at the point in the industry where we're moving past just evaluating whether there are benefits of telehealth or if this is something that we should or shouldn't be incorporating into our standard delivery of care. But we're really shifting over in the industry to getting past the actual limitations and getting reimbursed for providing telehealth services. So let's look at a couple of different delivery models for telehealth. Typically in the past, we would consider telehealth as being that standard audio-visual connection between a patient and a provider that are in two different locations. But as we've seen over the last couple of decades, telehealth has actually been applied to a lot of unique situations. So we're seeing telehealth being used out in the field as a part of ambulance delivery models. They're using them in schools, so school-based telehealth clinics have gained a lot of popularity, and this really helps by not having students having to get checked out of school or transported over to their physician or their pediatrician. We're seeing a lot of traction with telehealth with chronic care management. So CMS has created different reimbursement avenues for utilizing telehealth and managing those chronic care patients. And of course, we're seeing a lot of traction in telehealth with several different specialties. So let's shift over and talk about the legal and regulatory limitations for telehealth. Licensing is still probably the biggest limitation that we get when it comes to providing telehealth services. So currently, for a majority of states, you do have to be licensed as a provider in the state that the patient is located in. So regardless of where as a provider your physical location is when you're providing the actual telehealth service, you do have to hold a license from the same state where the patient is located. Now, there are a couple of exceptions to this. So there are 9 states who have offered cross-state licensing. So this is essentially offering a limited way of, an expanded way of allowing providers who have licenses in, say, neighboring states or other states to offer telehealth visits to patients that are located in their state without actually having to obtain a license. And there is a interstate medical licensure compact. Now, 22 states have actually adopted this one, and this was essentially created as a fast-tracked way for physicians to gain a license in a state where they have telehealth patients. And you can see a list of both those 22 states for the license compact and the cross-state licensing there as well. Since we are limited on time, I won't go into all of the legal and regulatory considerations when it comes to telehealth, but if you are interested in starting a telehealth program, it is really important to pay attention to these different areas. So credentialing and privileging is an area to pay particular attention to. Privacy always applies when we're doing any sort of delivery of healthcare services, and telehealth is no exception to that. Some states do require a written consent signed form in a documented record that's saying the patient is allowing you to perform telehealth services before you ever have one of those services. And then some states do have limitations around establishing a physician-patient relationship before any telehealth services do take place. And that will differ from state to state what the actual meaning of a physician-patient relationship is. A lot of states have adopted that if you have had a face-to-face visit at least once before, that does count as establishing a patient-physician relationship. And online prescribing is also another area to pay attention to. There are a lot of limitations, particularly when we think about controlled substances, as to what can be prescribed over a telehealth visit and what cannot be. So we're going to shift gears and talk a little bit about the reimbursement when it comes to telehealth. When we're out in the field as consultants, we typically see that a lot of people aren't asking questions about, what are some of the benefits of telehealth, or are my patients really going to want telehealth visits? We're kind of moving past that. Telehealth has really gained a lot of adoption, especially this last decade, and we're moving into, we know we want to offer telehealth visits, we know our patients will respond well to it, we know we're going to have to incorporate telehealth if we want to stay in the healthcare industry. Now, how do we actually get paid for it? So let's take a look at the differences between commercial payers, Medicaid, and then, of course, Medicare. So when we're talking about getting reimbursed for telehealth services, there are a couple of different factors that we want to consider. The first one would be patient setting requirements. Now, you may hear this term pretty often in the telehealth industry, but it's called the originating site. Now, the originating site is always the location where the patient is. Some states allow patients to be located, let's say, from their home or from their place of work. There aren't necessarily as many limitations to where those patients have to be located, but certain states, certain payers, and Medicare do put restrictions on where that patient has to be, and we'll go into that in a little bit more detail. There are a handful of states who have also set geography or distance minimums. This is a little bit unique. There's only about 3 or 4 states who really set this minimum as a requirement, but some states do limit the distance that the provider has to be from the patient that they are providing telehealth services to. South Dakota and North Carolina are probably the 2 that are most notable, but in those states, you have to have a certain number of miles in between you as a provider and the patient. So they can't be located in the same community at the time of the service. The third one is the provider or the facility guidelines. Now, just like the originating site is where the patient is located, the distant site is where the provider is located. And there's a lot less limitations when we think of where the provider has to be located. Mainly, we get limitations when we talk about where a provider is credentialed, privileged, and, of course, licensed. But there are some payers and some states who will set limitations on where the provider has to be when they are performing these telehealth services. And then, of course, there are only a handful, or a limited number of services that are actually reimbursed during telehealth visits, and that's going to differ from payer to payers and from state Medicaids to different states, of course. And we'll talk about that specifically with Medicare as we get a little further into this webinar. And possibly the most important factor to pay attention to is how you're actually billing for these telehealth services. There are a few nuances when it comes to billing for telehealth that are different than when you're billing for regular face-to-face visits. So it is important to pay attention to how you are sending these claims and submitting them in order to fully get reimbursed for the services that you are providing. So let's first take a look at private and commercial payers. Now, every single state and every single payer does have different rules when it comes to how they're going to pay for telehealth, what circumstances, which services they'll allow that are considered telehealth, and even the definition for what counts as telehealth and what doesn't is going to differ between payers. We are seeing that a lot of our bigger known payers in almost every state are in one way or another paying for telehealth. The circumstances do differ, but the fact is that reimbursement is there. And when we look at private or commercial payers, there is legislation known as parity law that can be enacted in every single state that essentially states that if you are reimbursing for telehealth services, you have to reimburse at the same level that you would if that service was provided as a face-to-face visit. Now, this doesn't mean that, blanket statement, every single service is paid for in states that do have parity law. There are still a lot of limitations that commercial payers can set that limit, the circumstances or the situations that they do reimburse for telehealth, but it's still a really big move in the industry for getting these services paid for. And as you can see by this map, all of the blue states are the states that have enacted some sort of telehealth parity law, so you can tell that there is reimbursement happening across a majority of our country. And even the ones who don't have at least proposed parity law, so there are very few states who have no parity legislation in place, and we've kind of seen this gradually changing throughout the year. So as every year passes, there are more and more states who have been adopting this parity law, so it's becoming quite standard. Really similar to commercial payers, Medicaid is going to differ in how they reimburse by every state. But if we look at some of the statistics, there are 48 states and DC who do reimburse for live video. An additional 21 states reimburse for remote patient monitoring, and 15 states actually reimburse for store and forward. And then there's 32 states that reimburse for a transmission or facility fee, and we'll talk about that in a little bit as well. But from these stats, you can tell that Medicaid has really understood that telehealth is a big part of how we're going to be delivering care in the future. And that's why we're seeing so many different Medicaid programs allowing for reimbursement when it comes to telehealth. And lastly, we're going to talk about Medicare. So typically we kind of consider Medicare as being the most limited in terms of what is being paid for and reimbursed when it comes to telehealth visits. And they have a lot of restrictions on the originating site, which is where the patient is actually located. So firstly, in order for anybody to actually receive reimbursement from Medicare for providing telehealth services, they do have to be located in a rural health professional shortage area, or they have to be located outside of a metropolitan statistical area. And then in addition to that, there's also limitations on the actual location or the facility type where the patient receives care. So for Medicare, a patient can't be located at their home, they can't be located at their place of employment or anywhere like that. They do have to be in one of these types of facilities. So physicians' offices, hospitals, critical access hospitals, rural health clinics, SQHCs, and then a couple of others that are on this list. And if you have any questions on whether your facility or your location meets the requirements for CMS in terms of what counts as an originating site, there is an HRSA lookup tool, and I've linked that here. So you would just type in your address or your zip code and city, and it'll tell you if there is telehealth payment allowed from Medicare. Now, when we talk about the eligible providers who can provide these telehealth services, there's also limitations on the type of practitioner who can provide telehealth services and actually receive reimbursement for it from Medicare. So this includes physicians, nurse practitioners, physician assistants, nurse midwives, clinical nurse specialists, and a few other on this list. In addition, we always want to consider which services are actually going to be reimbursed by CMS and Medicare. And this list is actually updated every year. And for 2018, this list was actually expanded a lot. So to take a look at all of the services and HCPCS or CPT codes that are covered and reimbursable under Medicare, you can click this link right here and it'll give you a list of all of those services that do count as reimbursable telehealth visits. And lastly, we're going to talk about how to actually bill for telehealth. So specifically when we're talking about Medicare, there are a couple of modifiers that you can use to indicate that the visit that you provided was a telehealth visit and not a regular in-person, face-to-face type of visit that you're usually billing for. The GT modifier is typically used to indicate that it was a telehealth visit, but there is a GQ modifier which is specific for states like Hawaii and Alaska, which have to reimburse for the distance, so for store and forward as well as for providing the live video telehealth services. That was before 2017, so that's typically how people were coding and getting billed and reimbursed for telehealth visits, but starting January 1st, 2017, there is a place of service code that you can use on claims to identify that the service that you provided was a telehealth visit, and that place of service code is place of service 02. Now, post 2017, all claims should have this place of service code on it, but the GT and GQ modifiers are still being accepted by CMS. So we're seeing a little mix of both in the industry. People are still using the modifier and as well as using the place of service 02 code indicating that this is a telehealth service. Now that is for the professional services component of providing telehealth visits. Now there is a facility fee component that Medicare and a lot of Medicaid programs will reimburse for. So facility fee payment is the payment that would go to the originating site, so that's where the patient is located, to help facilitate the actual telehealth visit. So by using the HCPCS code Q3014, it's indicating that you weren't providing the professional service component of this visit, but you were facilitating that telehealth visit. So you do get that facility fee. And for calendar year 2018, CMS has determined that that fee is going to be either $25.76 or 80% of the actual charge for that visit. It's going to be whichever one amounts to the lower number of those two. I have included a couple of resources here for you guys. A lot of the reimbursement and regulatory limitations that we talked about in this webinar are covered in more detail in the 2018 Reimbursement Resource Guide. There's also a white paper on 5 things you need to know about telehealth, as well as an infographic that highlights a lot of the adoption statistics around telehealth going into 2018. And there are a couple of website resources, industry resources that I want you guys to be aware of that you can leverage. So the National Telehealth Policy Resource Center is a great resource for all things telehealth when it comes to reimbursement and legal and regulatory policies. They keep an up-to-date kind of lay of the land in terms of all of the different rules and regulations that are going on, and they separate it out by state. So if you have any questions on, in your specific state, what's covered, what isn't covered, which payers are paying for it, this is a really great resource to use that you can look up those specifics for your state. And last, there is a CMS fact sheet. This fact sheet outlines a lot of what CMS is and is not reimbursing for, and they just recently updated this. So for 2018 calendar year, all of the information is up to date in terms of the services that are covered, the amount that the facility fee will be, and what type of codes you do have to use on claims in order to get reimbursed. And with that, I'll turn it back over to Alex, but if you guys have any questions, we're happy to take them.
Thank you, Reeya. We had a few questions come in, so we'll go ahead and take those. The first question asks, does it matter where the provider and patient are during a telehealth visit?
Yeah, absolutely. So we kind of talked a little bit about it, but where the patient is, that's called the originating site. Now, there are more restrictions on the patient location or the originating site. So some states are allowing patients to be at home or be at work or school. They're not really setting any limitations on where the patient actually has to be. Texas is a really good example of this. Just last year, they passed this law that does allow a patient to be located at home. And there are a couple of other states who do the same as Texas is allowing. The provider location, again, it's a little bit less restricted in terms of where the provider has to physically be located at the time that they're dialing into a telehealth visit. But what we want to pay attention to there is where they're licensed. So it's important to know that the patients and the provider have to be licensed in the same state, even if the provider is, joining that telehealth visit from a different location at the time. It's the licensing that's a little bit more restrictive when we think about the provider location.
Great, thanks. So let's go ahead to the next question here. How do I know if my state covers telehealth?
Yeah, that's a really great question. I think the biggest issue that we have when we think about telehealth and reimbursement and what's allowed and what's not allowed is that there aren't a lot of rules that apply across the board. Every state Medicaid program has different rules, every commercial payer has different rules, and each commercial payer has different rules for every single state. So outside of Medicare, it's really hard to know, kind of what exactly is being covered, what isn't being covered. So it takes a little bit more digging. That resource that I linked to on the previous slide is a great resource just to get a good start. So if you are interested in, either your Medicaid program in your state or the commercial payers in your state, from a high level, if you want to know what they are reimbursing for, that's a great place to start. But every state Medicaid program does publish a handbook that outlines different definitions and covered services for telehealth and what's covered. So referring to that state Medicaid handbook would be a really good idea. And then for the commercial payers, the easiest way to get information on what you're going to be reimbursed for and what you're not is to talk to the individual who you actually manage your contract with. So just kind of understanding what your contract covers and what doesn't with each of those payers is a really important first step when it comes to telehealth and getting reimbursed.
Perfect. So actually, along those same lines, do you anticipate that insurance companies will continue to update their policies to include more telehealth plans or services?
Absolutely. So we've actually seen in the industry that commercial payers and the different state Medicaid programs are actually the biggest adopters and proponents of telehealth. As I'm sure a lot of you guys have noticed that even with your own insurance providers, that there are some sort of telehealth services that you can utilize that are offered through your insurance. So absolutely, I think that we are going to see an even greater adoption of what's covered as telehealth, what's reimbursed as telehealth, and I think the commercial payers are really kind of leading the way in terms of how much they are reimbursing.
All right, and then can I offer telehealth to my existing patients who don't want to miss work or school?
Yeah, absolutely. A lot of people tend to think that, telehealth is a way for, either to increase your patient volume or get connected to providing services to patients who are, let's say, in rural areas or areas where there aren't any specialists. But a really great use case for telehealth is to offer the convenience of telehealth visits to your existing patients. So they may not, have that distance limitation. They may still be located in your community, but offering telehealth is a great way to offer an additional service line to your existing patients. Now, we do want to pay attention to some of those restrictions. We did talk about with North Carolina and South Dakota that you can't be in the same community. But outside of those two states, for the most part, we don't have that issue. So if you are interested in using telehealth to just offer additional convenience to your existing patients, that's a really great use case for it.
All right, great. So in the interest of time, I'm going to go ahead and conclude today's webinar, but I would like to note that any questions that were asked during today's call, and we did have quite a few come in, that we didn't have time to address during the Q&A will be followed up with post-presentation, so your questions will be answered. And thank you, Reeya, and a special thank you for everyone taking the time to attend today's webinar, Telehealth Past, Present, and Future. And as a reminder, today's slides will be shared in a follow-up email, and we'll also include a link to review the recording of the webinar in case you want to review again or share with any of your peers. So on behalf of Azalea Health and our presenter, thank you for joining us today and have a great rest of your day.